I'm going to tell you in the next 15 minutes a little about a couple of studies we've done that address the issue of obesity and metabolic syndrome. And as you're surely aware, these are two highly prevalent and age-related conditions, and we believe they may be contributing to HAND. These conditions have increased dramatically over 3 decades. The risk of diabetes is increased by obesity and by HIV, and the prevalence of overweight and obesity is now similar in HIV ART-treated patients and the general population. In other words, our HIV-treated population has the same increase in overweight and obesity that the rest of us do. Body mass index, for instance, is similar in HIV-negative controls and HIV positives in the U.S. Navy and in women in the WISE cohort. I think I need some help. Maybe. There we go. I'm all right. All right, this field of the metabolic impact on HAND was born by a report from Victor Valcour and others in Hawaii of a relationship of diabetes to HIV-associated dementia. It's shown here that the HIV dementia patient, whoa, try again here. Let me see here. That the HIV dementia patients the diabetes patients here were more likely to have HIV dementia, 20% of them, than either those with less severe levels of cognitive impairment or normals with an odds ratio of about 4. So based on that, we looked at the charter cohort and looked at waist circumference as a measure of central obesity and BMI as an overall assessment of obesity. In 130 HIV participants, we had lots of different sources of data from that study, and were able to perform multivariate models that predicted neurocognitive impairment using these variables above in a subgroup of about 55 patients in which we had both of these measures. And we found that the body mass index on this ordinate or abscissa, and waist circumference on the ordinate were highly correlated, as you might expect, but that at every level of BMI, the patients with neurocognitive impairment tended to have higher BMIs, waist circumference. When we addressed this then in a model, we found, as we expected, modeling for NCI, that having a diagnosis of clinical AIDS, an odds ratio of 50 or so, diabetes, and waist circumference, but not BMI when waist circumference was considered, increased the risk of NCI. And even though this looks like a small ratio, this is per centimeter of waist circumference, so it becomes a much more impressive p-value over here. Now, how might central obesity contribute to systemic inflammation in HAND? Well, we know that central obesity induces invasion of the deep subcutaneous and visceral adipose tissues by activated macrophages. They form crown-like structures around adipocytes, shown here in comparison to normal fat, and that these activated macrophages produce a number of pro-inflammatory cytokines, of which we've concentrated on IL-6, and thereby potentially induce metabolic syndrome and CNS inflammation. So after making this observation, we decided to look at the relationship of inflammation to abdominal obesity and neurocognitive impairment. And I worked with Fred Sattler, a colleague at USC, who's an infectious disease physician, but has taken a long-time interest in the metabolic complications of HIV. We did a prospective cross-sectional study of 152 charter participants on which we had the usual data, and we added biomarkers for neurocognitive impairment measured in CSF and listed here, and in plasma, as you can see, including IL-6, soluble CD14, and soluble CD163. And we confirmed in this group the relationship between waist circumference and increasing deficit scores. And the two lines you see here depend on whether we include these points down here in which there was no deficit or not. We also found a strong relationship of global deficit scores to the log of IL-6, illustrated here with the same analysis excluding the unimpaired patients. And so we've had the feeling that IL-6 might be, as a marker of systemic inflammation, now giving us some information about the mechanism. When we looked at IL-6 by tertiles, we found that in the high IL-6 tertile, there was a strong correlation here between global deficit score and waist circumference, whereas that was not true in those in the lowest tertile, or actually in the middle tertile as well. So it seemed that this effect of systemic inflammation and waist circumference may be applied primarily in people at the highest levels of both. In our modeling, in a path analysis, we then ask the question, how is waist circumference here related to NCI, or global deficit scores? Are there multiple pathways involved? And in fact, we found that there was. One of these pathways goes through IL-6, the other doesn't. This is an analysis looking at a subgroup of patients with high levels of CSF CD40 ligand, soluble form of that. And the model is, the strength of the model here is expressed as a p-value, but in contrast to our usual thinking about p-values, high p-values reflect better fit to the data in path analysis. So this model is strong with a p-value of 0.82. So this is our current working model about how central obesity may be related to NCI and brain damage. We think that there is central fat inflammation, and this is as measured by IL-6, and this is perhaps inducing CNS inflammation by one of a number of pathways. And we also think there may be a metabolic effect of the hyperglycemia and insulin resistance, perhaps operating through small and large vessel atherosclerosis. And so at this point, we feel that in patients in the top third of central obesity and systemic inflammation, there are strong correlates with NCI, that the central obesity may contribute by both an IL-6 dependent and an independent pathway, and that by increasing systemic and CNS inflammation, central obesity from either HIV, the ART effects, as just a consequence of the general epidemic of obesity in the population, may be contributing to this sustained high level of hand we see in our ART-treated patients. So what can we do about this? It seems that we can attempt to reduce central obesity by a number of methods, but there is an interesting drug approach involving this drug, tesmorelin, an FDA-licensed growth hormone releasing factor analog. That is something that will increase growth hormone levels over time. We could certainly try exercise, diet, and bariatric surgery, perhaps, in the most extremely obese patients. There's also an anti-inflammatory approach with NSAIDs of various kinds, salsalate being a candidate, and there is anti-IL-6 monoclonal antibodies that might intervene in this whole pathway. So I'll close at this point.